Hi, I'm Glenn Bauman. I'm a professor in the Department of Oncology at Western University in London, Ontario, radiation oncologist, and I'm happy to present some practical examples of integration of PSMA PET CT into radiotherapy. So in our first practical session, we'll talk about primary and salvage pelvic radiotherapy. We'll cover off some of the standardized scales that are available for interpreting PSMA PET imaging and how that can influence the design of our radiation treatments. We'll talk about some of the practical aspects of image fusion and delineation of PET-identified gross tumor volumes, and then use a couple of examples from Patron and Argos to illustrate how these are integrated into the primary treatment of prostate cancer and a case of local recurrence after prostatectomy. So the primary score has been developed to help identify sites of prostate cancer in the prostate. It classifies patterns of PSMA uptake in terms of things like symmetry, location, and intensity. And those patterns of uptake that are most suspicious for prostate cancer are those that tend to be focal and more intense. So we can see in the primary scores 3, 4, and 5, you have more intense focal uptake either in the central zone or in the peripheral zone. And in score 5, intense uptake alone with an SUV max of 12 is suspicious for prostate cancer regardless of location. So the patterns of uptake that are less suspicious tend to be either low or no uptake in the prostate, or symmetric uptake that tends to spare the periphery of the gland and tends to be lower SUV. So when we're delineating intraprostatic foci for giving higher radiation doses or directing brachytherapy or something like that, we can use the primary score to help guide us in interpretation of the PSMA PET to understand where the cancer might be located. And so in the primary score, they assign a molecular T stage, which also reflects the extent of the cancer, whether it's unilateral or bilateral within the prostate, and whether it looks like it might be extending outside the prostate or into adjacent organs. And again, we can see that the primary patterns 1 and 2 are considered non-malignant, where 3, 4, 5 are considered malignant. Now, how we integrate this information into our radiation planning, and how do we integrate it with other types of prostate imaging like MRI, has been the subject of a number of studies that have utilized imaging prior to prostatectomy and then the histological information from prostatectomy to help correlate the PET or MRI findings with the actual location of cancer in the prostate. So this correlation of these pre-surgery images and post-surgery pathology has really helped us to understand that both MRI and PET will help us identify foci of cancer in the prostate. So in the upper left here, the PSMA PET uptake in the left lobe and the changes on ADC and T2 in the lower left, corresponding to the focus of prostate cancer seen in the histopathology in the left side of the prostate. What we find from these types of studies is that there is a bit of difference in terms of the correlation of the actual volume of the cancer compared to the pathology, where the MRI tends to underestimate the volume of the cancer somewhat compared to PET, and that the volume correlations are a little closer between histology and PET. And again, the large meta-analysis that was done looking at the ability of PSMA to identify intraprostatic foci tells us that it has a excellent performance in identifying intraprostatic foci. If you use combined PSMA PET and MRI, that performance increases a bit, but PET on its own has excellent performance as well. The issue that we face as radiation oncologists is that imaging can often direct our attention to a region of the prostate, but then we are faced with delineating a boundary or contour or volume that reflects the underlying extent of the prostate cancer. So these same studies that have done correlations between histology and imaging have tried to look at optimum parameters for using PSMA PET to delineate the cancer in the prostate. And these could be manual techniques where you window and level the PET scan to highlight the foci of cancer within the prostate and just by eye determine where you think the edge of that high PET signal is and draw your volume that way. Or you can use a thresholding technique where you can, within a volume, determine what the SUV max is, so the maximum uptake of the tracer, and then automatically delineate volumes based on a percentage of that SUV max. And in the studies that have been done, there is some tracer dependent differences, but in general, for PSMA 1007, for a manual technique, using an SUV window of 0 to 10 for manual outlining seems to be associated with a good correlation with underlying histology, or a threshold of 20% of SUV max seems to work well. For gallium PSMA, the windowing is a little bit different for the manual outlining, but again, a 20% SUV max tends to work relatively well. If you restrict the SUV max to a higher value, say 30 to 40%, that's going to delineate a smaller volume. And what has been found in these studies is that if you are doing a diagnostic test like a biopsy, you might want to increase your specificity. So if you're going to biopsy something, you want to know that you have a high chance of biopsying actual cancer that's there. So they recommend a higher SUV max for diagnostic interventions like biopsy, so 30 to 40%. So if you put the localization within the prostate aside for a moment, talk about PSMA PET and its ability to detect lesions outside the prostate, then this is approached a little bit differently. And primarily here you're dealing with something called a PSMA expression score, where you look at uptake of lesions and then compare them to normal anatomic structures, or uptake or intensity of PSMA PET in physiological structures such as the blood pool, the liver, and the parotid. And then PSMA expression score is assigned based on where a lesion lies in relation to those other organs. And then those lesions are assigned a designation of malignant or non-malignant based on both the location and their intensity of their uptake. So in general, lesions that show up in areas typical for prostate cancer spread, such as regional lymph nodes, might be flagged as malignant with a lower PSMA expression score versus those appearing in atypical locations where you would want to see a higher PSMA expression score to be more confident that those are actual prostate cancer foci. The interpretation of the PSMA PET scan outside the prostate is then along the lines of the traditional TNM staging, so looking at uptake within regional lymph nodes as well as extrapelvic lymph nodes and bone and viscera, and then using that pattern of PSMA PET detection, you can then assign a molecular stage, a molecular N stage, a molecular M stage. And again, we see that in detecting lymph nodes in high, intermediate, and high-risk patients, the performance of PSMA PET varies a little bit, but in general is relatively sensitive for picking up regional nodal involvement. And putting all this all together, one can then have a true TNM, molecular TNM staging, and that is the premise of the PROMISE scoring, where you use the primary criteria to determine the T stage, and then the PROMISE criteria for the N and M, but together you have a molecular TNM staging system. And the prognostic importance of this molecular staging is being demonstrated through large multi-institution registry studies, and the results here showing that based on this PROMISE score you can identify a higher risk group of men, largely with M1 disease or extra pelvic nodal disease, and that those high-risk men overall have a worse survival than men without those high-risk features. So again, validating the PROMISE score as being prognostically important. So here we have a case which would be a PROMISE score T2N1M0. So fairly extensive disease identified within the prostate with an SUV of 41. So that automatically is a primary score 5. Within the left external iliac lymph node, SUV of 11, which is an expression score of 2. So above liver but below parotid. By virtue of its location, it's also in a typical location for spread, so you have good confidence that this is a pathologic lymph node. And interestingly, if one looks at the CT alone, without the overlaid PET signal, the lymph node in that area is sub-centimeter and would likely not meet pathologic size criteria, so by conventional imaging would be an N0 case, but the PSMA PET definitely highlights that lymph node and gives us the molecular N1 stage. So with the Patron trial, we saw that men randomized to PSMA PET imaging had intensification to PSMA PET identified lesions, either through expansion of volumes or increase in dose. And so we approached this case with Patron style planning. So again, if you want to start to adapt your radiation plan to the findings of the PSMA PET scan, the first thing we need to do in integrating PSMA PET into the radiation planning is we have to fuse those two sets of images. So the PET CT with the planning CT used for the simulation for radiation planning. Now, since you have CT as the common denominator between those two image sets, you can typically fuse these fairly easily based on the bony anatomy from the two CTs, which will get you very close, and then you may need to adapt the fusion a little bit because the two sets of scans are acquired with men in slightly different positions. But here we have our simulation CT. Here is the PET CT, and you can see just in comparing those two images, the couch tops are different. So the man is lying a little differently for the two studies, but the actual bony anatomy lines up pretty well. So once we have that fusion accomplished to our satisfaction, we can now look at the PET component. We can identify the area of uptake here, and now we can start to delineate a gross tumor volume based on the PET. So one way to do this is I could window and level this in that 0 to 10 range, and then do a manual contour, or I can use automatic thresholding and delineate the volume based on a percentage of the SUV max within that volume. Here we see the PET signal sort of integrated with the simulation CT, so you can see the two scans blended together. So now if we use a 20% SUV, you can see that the contour in a light green is basically encompassing all of that PET signal, not just the very intense red areas, but the lighter areas like the light green. If we start to adjust the threshold to a higher SUV, you can see now you're excluding some of the PET signal. The green contour is now hewing more closely to the red area. And then with a 60%, you now see that it's pulled that GTV volume in even tighter. So you would be very confident that that volume contains prostate cancer that you would want to boost, but perhaps you may be underestimating some of the actual volume of cancer within the prostate gland. So we actually went with a 20% SUV for this case because we know there's good correlation with the underlying cancer volumes with that 20% SUV. And so now we have a superimposition of that PET-defined GTV on top of the planning CT. So you can see the underlying prostate there. And then we can go ahead and segment all the other areas like the prostate boundary, the bladder, the rectum, all the normal structures. As far as the lymph node goes, here we really don't try to identify substructures within lymph nodes. We're really just trying to identify involved lymph nodes. So we know that based on the prior images that this lymph node in the panel on the left is the one that was highlighted with the PET signal. So we can now contour that lymph node based on the anatomic information from the CT. So in green here, we've circled the lymph node based on the structural information from the CT. The red contour, larger red contour, is outlining the other nodal regions at risk. And now if we look at the superimposed PET, we can see that the PET signal is close, but it's not directly overlapping. That is because the fusion was optimized to improve the concordance of the fusion at the level of the prostate. So in planes outside of that area, sometimes the fusion is a little bit off, but here we're not as concerned about using the PET to delineate the boundaries of the lymph node. We get that information from the CT, so the PET is really just helping to highlight the lymph nodes we need to pay attention to. And again, we have combined plan here, which is boosting the involved lymph node to 60 gray and 20 fractions. The regional lymph nodes are receiving 44 gray and 20 fractions, and the intraprostatic tumor is receiving 66 gray and 20 fractions, with the whole prostate receiving 60 gray and 20 fractions. So another case here, in this case we've identified the cancer intraprostatic based on a hybrid PET MRI. So we have an ADC scan here which identifies an area in the peripheral zone near in the midline posteriorly, and we can see that on T2 weighted MRI as well, and on PET this corresponds to an area of high uptake. SUV is 12, so it's automatically a primary 5. There were no lymph nodes identified, so we get some molecular imaging T2 and 0. And again, we now have the ability to, using that hybrid PET MRI, delineate the area of focus here and design a plan which will treat the whole prostate, in this case with a stereotactic technique to 35 gray and 5 fractions, boosting the PET MRI identified nodule to a total dose of 45 gray and 5 fractions. And studies like Hypoflame have demonstrated this approach is safe, and studies like FLAME, which is a randomized study, have demonstrated this type of focal boost is efficacious and improves disease control. So in this study, we looked at PET response after this type of focal boosting, and we saw that SUVs within the treated lesions went down over 6 months, and this corresponds with other studies which have looked at patterns of PSMA PET response after targeted radiotherapy, and shows that SUV decreases of 50 to 100% are seen in the months after radiotherapy, with a nadir in the PET uptake by about 6 to 9 months. So in the setting of post-prostatectomy, PSMA PET can be a little bit more challenging depending on the tracer. Tracers like gallium and DCF-PYL are excreted through the urinary symptoms, or through the urinary system. So high tracer uptake within the bladder can make it challenging to identify sites of recurrence within the prostate bed. In this case, we used a tracer 1007, which is excreted through the hepatobiliary system, so relatively less uptake in the bladder. So this allowed us to see fairly extensive recurrence within the prostate bed and an anastomotic site. And this was actually also visible on endoscopy, high SUV, but no regional nodal recurrence. So molecular TR, R standing for prostate bed recurrence, N0, M0. So in this case, given it was a post-prostatectomy setting and given the extent of recurrence, we chose not to dose escalate, but the pattern of PSMA uptake certainly allowed us to adapt our volume to make sure that we were covering all the potential sites of recurrence in the prostate bed. And then we treated this to a standard dose of 66 gray and 33 fractions, conventional fractionation, and regional nodal radiation to 50.4 gray and 33 fractions. So that concludes the section on practical applications to local regional disease for use of PSMA PET in radiotherapy.